And all the commissioners, can you hear me?
Yes.
Great. So welcome to the Maryland Healthcare Commission March 16th, 2023 meeting. I want to welcome commissioners and members of the public. This meeting is a hybrid commission meeting. There are several commissioners in room 100 and the rest of the commissioners are participating by Zoom. Given that this is a hybrid meeting, additional ground rules will still apply. I will begin this meeting with a roll call of commissioners. During the meeting, I will ask the commissioners and presenters identify themselves before speaking so that commissioners and members of the public will know who is talking and have the same knowledge as those of us here in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask that commissioners and presenters mute their electronic devices when they are not speaking. I would also like to ask commissioners attending remotely to avoid putting substantive comments in the chat, as it can be difficult for those of us in the room to see the comments. As previously stated, MHCC posts documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. I will now call the roll. First up, Commissioner Bandari.
Here.
I see you, sir. Commissioner Boyer. Commissioner Boyle. I think Commissioner Boyle is next. Commissioner Brumbot.
Here.
Welcome. Commissioner Buzinski is here in the room.
Yep.
Commissioner Cheatham. I think she said you. Commissioner Jensen is here. Commissioner Metz.
Yes, sir.
Welcome. Commissioner O'Connor. Commissioner O'Grady.
Here.
Welcome.
Thank you.
Commissioner Ojikutu.
Here.
Welcome. Commissioner Wang.
Here.
Welcome. And Commissioner Wood.
Here.
Very good. Welcome. Nice. Got a quorum. Agenda item number 1, approval of minutes. Included in your packets are copies of the minutes from the February 16th, 2023 public meeting of the Commission that took place in person and by video conference. I will entertain a motion to approve the minutes of the February 16th, 2023 Commission meeting. Do I have a motion to approve the February 16th minutes?
Motion.
All right, so moved by Commissioner Buzinski. Is there a second?
Second.
Jensen, seconds. Anyone want to discuss the minutes?
No, they're not.
Okay. All in favor?
Aye.
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 Are there any opposed? The minutes are adopted. On to agenda item number 2, update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Ben, the Executive Director, do you have us any updates that you want to add?
So first off, I want to recognize Commissioner Metz. This will be his last meeting as I've informed the commissioners. Governor DeBoer's appointment office has made new appointments for both commissioners who term expired October of 2022, as well as commissioners' appointments who terms will expire in September of 2023. Commissioner Metz's term expired in 2022. He graciously served until a replacement has been identified. Jeff has been really steadfast in his participation and his unbiased, his willingness to offer a unbiased view of activities going on in the nursing home industry in particular, but more broadly as well in long-term care. Generally, I want to personally thank him for his service and hopefully, as the appointment secretary said, encouraging people who are aging off commissions to consider serving another board or commission for the Moore administration. I want to also emphasize what they told me, which was that the decision to replace MHC commissioners was not based on a desire to replace existing commissioners, but really a determination that they were going to apply the rule that commissioners who, and this applied to boards as well, served 2 terms, which they define as a partial term and a full term, as serving meeting the requirements under the law. That's advice from our attorneys confirms that that is an interpretation they could make. That's not one that I had conveyed to commissioners previously, because it had been something that historically the rule had been 2 full terms would warrant full service. So obviously elections change and people can take different positions, but they were very emphatic about this is not being something they were just replacing people, but they felt that if commissioners and other board members had served 1 full term and a partial term, that constituted their service. So I do hope that Commissioner Metz would consider other opportunities to serve the state, but I do want to thank him very much for his many contributions to the commission over, I think it's 6 years. So thank you very much, Commissioner Metz. We are getting some feedback from someone. If you have your microphone on, please turn it off. Secondly, I also want to recognize Paul Parker, who will be retiring next week, after 22 years of service to the Maryland Healthcare Commission. As you know, Paul is the Center Director for Health Facility Planning and Development, but I just say he's the go-to man for all issues related to health planning and CON that we face here in the state. And he's really been a part of every single major health planning decision, as well as CON decision and determination over this last 12 or 13 years while I've been executive director. I appreciate his honest counsel throughout that period. He's going to be sorely missed, but certainly a retirement that includes a good component of time, as I understand it, in Hawaii is not something that can be denied forever. So we really want to, first of all, on me personally, I want to thank him for his support, his commitment.
Sorry about that.
Also, the Healthcare Commission, and we all the best going forward. So thank you, Paul.
Thank you. I just want to say for Commissioner Metz, when I started, he and I actually occupied the left side way at the end, and it was a real pleasure working with you, Jeff, over the past couple of years. Thank you so much for your service to the commission. It's been great. It's been great also working with Paul. I think for any of the commissioners that have taken on a CON dispute, just his support when I had one to work through was invaluable, and he's a real pleasure to work with. I think the same goes. I want to thank you on behalf of the commissioners for all of your work for us.
And for all of the commissioners that are in the room, there'll be a short little recognition after the commission meeting. If you want to linger, there'll be some additional sweets served as well that you need to tempt you further. But I think anyone who would like to hurry over from their remote place will certainly let you in as well. So thank you very much for all your work, Paul. We'll look forward to reports from Pacific in the months ahead. Moving on to my update, wanted to point out that you should have received the 2022 annual report and the 2023 through 2026 strategic priorities report. I especially want to thank all the commissioners who participated in the development of the strategic priorities report. I also want to call attention to the 2022 annual report on the governor. That report was the work of the commission staff, with special thanks going to Teresa Lee, who took a leadership role in developing the material this year and helping us make the report deadlines, which were linked to the presentation before the respective budget committees. Thank you all. A couple other pieces of information. We have been engaged with the Maryland Consumer Health Information Hub at the Hurwitz Center at the University of Maryland. They were given some funding last year under Senate House Bill 1082 that established the Hurwitz Center as a state consumer health information hub. They are bringing together all of the agencies in state government that are engaged in consumer reporting and outreach. And I have asked that the Hurwitz Center come forward in April to present their plans for working with MHCC and all of the other state agencies. Teresa is serving as the representative for the Healthcare Commission on ongoing work with the Hurwitz Center. Also, you should have gotten a copy of the MHCC quality letter put together by the quality measurement and reporting staff. It's going to be a new initiative that we will issue a newsletter on. This one, the high point is an interview with Dr. Ide. But if you haven't gotten that, please take a look at it. Or if you haven't received it, please let me know. I also wanted to inform you that the National Academy for State Health Policy has announced that Maryland has been selected to participate in a technical assistance program running through NASHB, through their State Policy Institute, to improve care for people with serious illness. The Maryland team includes Medicaid and MHCC, as well as stakeholders, the Hospice and Palliative Care Network, as well as consultants working with the center to advance palliative care. This is a technical services grant. There's no money involved, but we'll be working with their consultants and 4 other states, including Texas, Washington, Ohio, Maine, and Colorado. That's 5 other states over the next 24 months. And together we'll be examining how to roll out palliative care initiatives going forward. You'll hear today, lastly, you'll hear today from Paul on the work that he's led on the post-acute care work group that was convened by HSCRC to gather input on ideas for expanding the total cost of care in the next iteration of the model, which would begin in 2026. There are also 2 other work groups that we're participating on that have not moved this far along. One is the consumer engagement group that Teresa is participating on. That has a kind of an interesting set of ideas being bounced around, and which would be how do consumers share in any savings that are generated from the model. Yes, I know that there haven't been so much savings in 22 and 20, looks like in 2023, but we hope to turn that around. But there are ideas bouncing around about perhaps adjusting or reducing cost sharing for Medicare beneficiaries. kind of a out there idea, given that all care that Medicare beneficiaries receive is not through Maryland hospitals necessarily. There's also been proposals in that group to talk about creating a quasi Medicare Advantage-like benefit for people in traditional Medicare who would be potentially eligible for vision or dental or other services that would be available through savings generated through the hospital total cost of care saving model. Definitely not something for the faint of heart, but interesting ideas we're now thinking of bringing forward in the next stage of the model. Lastly, I don't see Madeline in here today, but I wanted to recognize her for the last decade or more. Madeline has served as our representative for the Maryland Charity Campaign. And throughout that period, Madeline at the commission has always met its contribution goals, which is not something that every agency can claim. I'm sure it's accidental that Madeline has headed this up. Not really. It's because Madeline has been diligent and probed and prodded people a little bit to get those contributions made. And I can't thank her enough for the work that she's done. It's not a job that I get a lot of volunteers for. So and she's appeared right now. So thank you, Madeline. And I'd like to give everyone give her a hand for something. It's a thank you. That concludes my update.
Yeah. Thank you, Madeline. That said, we can move on to action items. Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform the chair and state their recusal on the record when the agenda item is announced. For commissioners participating remotely who desire to recuse, they should remain silent, turn off their cameras, and mute their phones. Commissioners in room 100 who are recused should move to the small conference room. Before agenda item number 3, I just want to encourage the commissioners, take a look at the annual report and the finished strategic plan. I think the strategic report is very impressive. I think the commission did a good job of talking it through in detail. I think it's going to be a very valuable resource as we bring in new commissioners. But the annual report is a great way to see all these pieces that we see one at a time. Right now we're hearing about this work group. Now we're voting on that application. It's a very good way to see the whole picture of what all the different things that we do in one place. So I'd encourage the folks that haven't read it already, spend a little time with it. I read them, increases my knowledge of what we did last year, even though I was here. So it's a good resource to stay on top of things. And we will be encouraging the new commissioners as part of as they come on and spin up to do the same. Agenda item number 3 is the legislative update from Tracy DeShields, Director of Policy Development and External Affairs, who will review the bills that are a priority for MHCC and coming up for a bill hearing the next few weeks. Tracy, you have the floor.
Okay, great. Thank you. Next slide, please. Good morning. Good afternoon. I'm still on morning time. Sorry. Legislative session continues next Monday. Just quick facts or statistics. 69th day is Monday, March 20th, and that's the crossover date. That's where your Senate bills have to be in the House and the House bills have to be in the Senate. April 3rd is the 83rd day, and the budget has to be passed by both chambers during that time. Right now, there are probably a few more bills introduced than when I did this, but there are about 1,400 plus that have been introduced in the Senate and over 1,900 in the House. And we're tracking close to, I think it's exactly 193, but probably a few more. So we're around total of 200 bills right now. And some of those that we're tracking, we haven't taken a position on.
Are these like numbers, high, medium, or low?
Oh, for the
Or the Senate bills and the House bills and then the number of bills?
I would consider them, they would probably think they're low. I still think they're high, especially for a first year of a new term, a new governor and new legislators. So pretty ambitious.
Okay.
Now, some of that I will sort of qualify for the Senate. Some of those might be what we're seeing increasingly, or more bills being cross-filed. In other words, the same bill being filed in the Senate and the House, so that when they do crossover, they don't have to have a full-blown bill hearing, especially for complicated bills or somewhat controversial bills. So that could add to the number, but I'll give them that.
Look up the world record for most number of bills introduced in a legislative session.
I don't know if there's a record, but I could probably look it up. That would be my question for next time. Okay. Very good, thank you. So next slide, please. So right now, I'm just going to update on where things stand. So we'll just start with the budget. We've had our budget hearings, and they really were uneventful. There were no real questions being asked, nothing controversial that we have to think about. But right now, what has happened, the House moves the bill first. And the House right now, the budget bill is on second reader, and tomorrow it will be on third reader, meaning that when it goes to the House floor, they debate certain things, potentially talk it out, add amendments, if there are going to be any amendments at that time. And then they vote on it, it passed second reader. Then third reader would be the final passage, and then it will cross over to the Senate, essentially. And then the Senate, tomorrow, they have in budget and tax, full committee decisions. That's where the subcommittees have made their recommendations. And the full committee will take up those recommendations and decide on them tomorrow, potentially. And then the bill will be brought to the Senate floor probably midweek next week. So likely next Wednesday, which is the 22nd. And then the week of the 27th, the bills, they'll start to have conference committee on both those bills, on both the Senate bill and the House bill. Senate and the House will go into conference committee because they're inevitably going to be different. So next slide, please. Okay, so some of the bills that have had bill hearings in the last couple of weeks, Senate Bill 534, Preserve Telehealth Access Act of 2023. This is sort of like the second chapter of Senate Bill 3, the telehealth bill, the Preserve Telehealth bill. In this bill, for us in particular, we have another second part to our study, the telehealth study, where we're looking at sort of like outcomes, the effectiveness of audio only, what services are provided under audio only, that sort of thing. So that went, and it's scheduled for a bill hearing in the House next Tuesday, March 21st. And then Senate Bill 387, Task Force on Reducing Emergency Department Wait Times, did weigh in on this bill. I think we presented amendments which were not taken. So this will be an interesting one, since not sure who all, you know, the people that they have, they may have the right mix of people, but it's sort of, I don't know. The makeup of the committee doesn't change. I mean, the work group, task force. Senate Bill 648, House Bill 786. Bill hearings were held last week, late last week. Ben testified in both the House and Senate. If you want to make any observations around that, your testimony, Ben?
So this is an offshoot of actions that were adopted last session, which established a framework for allowing information, clinical information developed during care of patients in nursing homes to be shared through CRISP. And in parallel with that, a data vendor was identified for making information that nursing homes held within their EHRs useful for managing care at that facility. The requirement, however, is that the entity that is conducting this work to support the nursing homes real-time medical would be getting information on behalf of each respective nursing home for data that's in that nursing home's EHR, as well as information that nursing home may submit through an electronic health network / also known as an electronic claims clearinghouse. And the bill makes clear that those entities are responsible for providing that information through the vendor, shared with the vendor for purposes of care management and public health. We're not sure if there are real issues yet between clearinghouses, EHR vendors, and this particular vendor, but I think I see it as a step toward making sure that no issues crop up. And we will continue to monitor it. We believe there's a little lack of clarity regarding the ability of the of an EHR or clearinghouse to withhold that information. But should this pass, it will be very clear that the data has to be shared.
Does this apply to continuing care communities? How does this apply?
It would apply to a nursing home in a continuing care. CCRC, it's here for me to use that. But overall, the assisted living and the freestanding care or freestanding residents would not be nursing home care only at this point.
Got it. And then the next bill is Senate Bill 786, House Bill 812. We didn't testify on this, but we did provide a letter of concern. We raised some issues. The bill has been amended in the Senate, and I believe it's being worked on in the House. It is scheduled or slated to be voted, both bills this week. They did address our concerns that we raised in the bill, which essentially is more like technical, was related to information exchange and what the bill seeks to. But so we just needed some language cleaned up, and that was addressed in the bill. And then Senate Bill 234, Health Services Cost Review. This is just a bill. They just add clarifying language that they can use the criteria of the total cost of care when they are looking at efficiency criteria for hospitals. So we did weigh in on that, and it's also up for hearing next Tuesday in the House on March 21st. So we supported that. Amendments. Senate Bill 283, House Bill 418, Mental Health Workforce Development Fund. So this bill is moving. It's moved through the House and has crossed over both the House and the Senate. The Senate bill, I believe, is scheduled for hearing next Tuesday as well. We supported this bill. I don't think we had any amendments on it. It does require MHCC in coordination with the Behavioral Health Administration.
Should go to the next slide.
Next slide, please. Thank you. Yes.
And welcome, Commissioner Boyer, who has joined us midstream.
Hi, Commissioner. So we're just talking about mental health workforce development fund, that bill. So that would require us to do a study. Study is specifically on the behavioral health workforce as a whole. We would do this in coordination with the Behavioral Health Administration. I believe is it the Maryland Insurance Administration, as well as the only amendment was adding the Department of Labor into the other entity that we would work with regard to that study. The next bill is the Health Insurance Qualified Resident Enrollment Program. I forgot to put the bill number. This is one that we're just watching. It is, I would consider it more of a mandate bill, so it would be an expansion of ability for qualified resident individuals. These would be people who essentially are undocumented, but they're residents of Maryland, to obtain health care insurance through the Maryland Benefit Exchange. So it hasn't moved, so I'm not sure, but that doesn't mean anything. We still have a lot of time left for the bills to move. Senate Bill 493, House Bill 675, Commission to Study Trauma Center funding in Maryland. Testified on those bills that those were heard last week as well. Then testified. The bill was amended. They were sponsor amendments. It would make MHCC and executive director, as well as the MIMS executive director, the chair of that commission. And we would also, the two commissions, MIMS and MHCC, would staff, is charged with staffing as well. I don't think we had any issues with that at all. Senate Bill 509, House Bill 702, also was heard last week. There was a lot of questions from both committees, the House and the Senate, related to this bill. It is in subcommittee in the House today. We did offer amendments to the bill. Ben, do you want to just address those, your testimony and the amendments?
So, sure. The amendment that, so the bill as proposed generally had support of consumers of the SEIU, which brought the bill originally, and at least one of the nursing home associations. I'm not sure about each fam. Our amendment would do one additional thing, which would require entities that purchased nursing homes in Maryland to only purchase facilities that had no triple or quad beds, and that doesn't mean they couldn't acquire such facilities, but they would have to be downsized to single and quad rooms. There was some concern voiced about the implications on the marketplace of making it harder for purchasers to acquire the facilities that have these triple and quad beds. I would note that the trends are moving generally in the direction towards more individualized beds, rooms in nursing homes. In 2016, the CMS indicated that for new facilities, they would not be reimbursing for patients in triple and quad beds. A number of states have enacted measures that have made Medicaid payment for patients in triple and quads at reduced levels. It's also fair to say that there's litigation, at least in one of those states, Massachusetts, on the part of the nursing home owners on that. But we think this is within the scope of our authority to administrate the CON program. This amendment did generate some concerns from the associations, and we'll look forward to talking to them about it. But I think it definitely sends a message that are consistent with recognized practices and experience that everyone across the country has seen with outbreaks of COVID-19 in crowded facilities, that this would be a beneficial to consumers in particular. What this will require is us, should it pass, to take a look at our process for approving CONs, in particular, how we will balance on 5-star requirements with this particular requirement as people elect to come forward with CONs who wish to continue operating 3- and 4-bed facilities after the sale.
So, so with that, just move on to the next one. Senate Bill 582, House Bill 1148, behavioral health care treatment and access, like big behavioral health care bill. We are under this bill, we do have a study, again, it's telehealth, but it's very specific to behavioral health, how it's used in behavioral health. In particular, looking also at audio only, and how that is working to deliver behavioral health services. What exact services, how is it functioning, that sort of thing, cost reimbursement. So those are all the bills. Just so you know, there are about 12, what I consider probably 12 mandate bills, and I excluded bills related to Medicaid, even though some of the issues related to Medicaid, you know, somebody could say, oh, MACC, could you do a study on this, blah, blah, blah. So I excluded those. Right now, what I have calculated is about 12 mandate bills that potentially MHCC could be asked to do a study on if the bills don't pass. There have been several that we were asked to just provide comments on, preliminary information if we had it. One was Senate Bill 75 dealing with alopecia and coverage requirements, that cost. Also, I think we were asked about possible hearing aids and hearing aids and coverage. And then there was one more. Oh, Lyme disease, antibiotic treatment. So those three, we provided information on that. The bill that seems to be moving at this time, that actually we were asked to provide information for last session, but the bill was never introduced. The sponsor asked for information. We did the study, presented her with the information, and then as one that deals with breast cancer coverage, in particular diagnostic exams. So further supplemental exams and coverage, co-pays, cost sharing. That bill is essentially, I think, third reader in both the House and the Senate. So that would conclude my presentation. And while I don't have, last time I had words to ponder, but I don't have words to ponder. No, but I have something else. In light of, I have a trivia question. In light of National Women's History Month, just this month. So my question is, what US destroyer was named after a woman? Anybody? I don't know if that's allowed, but okay, go ahead, go ahead.
No. That was me saying, without saying it, that I don't know.
I managed to memorize half of the destroyer names before I got called away to something else.
Is it named after Geraldine Ferraro?
No. It's funny.
I think there is a Geraldine.
I think
Ferraro.
there is.
There is a ship
There's a
of the
Ferraro.
line.
Someone said, Ben, someone said Gabby Gifford.
No. Those are all
Amelia
big
Earhart.
guesses.
Amelia Earhart. I'm guessing. Who?
Okay.
Come on, tell us.
Okay. It is named the USS Higbee, DDG 123, and it was a Gearing class destroyer in the US Navy during World War II. She was the first US warship named for a female member of the US Navy, being named for Lena S. Higbee, a pioneering Navy nurse who served as superintendent of the US Navy Nurse Corps during World War I. And the Higbee launched on November 13th, 1944, and was commissioned on January 27th, 1945.
Yeah, thank you.
Has it been decommissioned?
Probably, it's pretty old.
Yes.
You're welcome.
Are there any questions on the report?
Sure, Sergeant. So the letters, most of the letters that have been covered in the 3 o'clock Thursday morning meetings have been shared. But if a commissioner wants to get a copy of that, how do they go about doing it? On the website?
Yes, it's posted on the website. So we will.
And where is it posted on the website?
It's posted on the website. Okay, so where we have meetings and we have the or is it on? It's on, yeah, it's where we have meetings and then we're posting them. We also make a note about our legislative policy calls. And so we're posting them there.
If you can't, commissioners can't contact
it on their login.
Either Commander Shields or Vincent Stefan in keeping with the naval parlance here. But yeah, reach out to us if you need a copy of either of any of the letters.
I think you're at least opposed.
Maybe.
I did have one question.
Sure.
If there are about 13 mandate bills, how many reports, just on either because you have intelligence about these particular bills or just given history, how many mandate reports might we expect to be next year? Is there any way of knowing at this time? Or
I don't think there's a way of knowing. We did talk about it a little bit internally. I would say right now there's a possibility we could get 3 requests, but I'm not sure. The max could be about 6.
Thanks.
You're welcome.
On to agenda item number 4. Certificate of ongoing performance for cardiac surgery services for the University of Maryland Medical Center, University of Maryland St. Joseph Medical Center, and MedStar Union Hospital. The next 3. Commissioner Jensen.
I'm going to recuse myself when we get to the MedStar Union Memorial.
Very good.
Also, give me just a moment to leave the room. Thank you.
The next 3 agenda items are for the consideration of approval of a certificate of ongoing performance for cardiac services for 3 hospitals, the University of Maryland Medical Center, the University of Maryland St. Joseph Medical Center, and MedStar Union Memorial. Buki Alaj, Program Manager, Acute Care Policy and Planning Team, will explain the purpose of the certificate of ongoing performance review process and then an overview of the staff reports for the first 2 hospitals.
Great, thank you. Good afternoon, Mr. Chairman, commissioners, the executive director, MECC staff, and members of the public. As previously stated, today I'll be making a presentation on the first 2 certificates of ongoing performance for the University of Maryland Medical Center and the University of Maryland St. Joseph Medical Center. The cardiac surgery chapter, COMA 10.24.17, it contains standards for evaluating the performance of established cardiac surgery programs to determine if a certificate of ongoing performance should be reissued. An approved certificate of ongoing performance for cardiac surgery services cannot exceed 5 years. The University of Maryland Medical Center is a 739-bed general hospital. It's located in Baltimore City, and it is part of the Baltimore Upper Shore Health Planning Region. Next slide, please. Thank you. So now I'll be sharing some of the findings from the review of the University of Maryland Medical Center's hospital's application and its alignment with the COMA standards previously mentioned. I will also be sharing briefly about a little presentation on confidence intervals during this presentation. The reason why we're doing that is because during the last meeting, there were some concerns about the bandwidth of the confidence interval and the placement of the national risk-adjusted mortality rate as related to the hospital risk-adjusted mortality rate on the confidence interval. So we'll be talking a little bit about that as well. And just to take a note, make a note that I might be using program interchangeably with hospital throughout this presentation. So one of the performance measures, and the first one identified on the current slide, is that all hospitals are required to participate in uniform data collection and reporting through the Society of Thoracic Surgeons, the Adult Cardiac Surgery Database. And the UMMC, the University of Maryland Medical Center, submitted all required data from January 2018 through June 2022. And for this reason, the hospital was found to be in compliance with the standard. The next requirement is that the Chief Executive Officer of the hospital shall certify that the hospital fully complies with each requirement for conducting and completing specified quality assurance activities. We did receive a signed certification from this hospital, and for that reason, they're in compliance as well. The third measure talks about the fact that the hospital shall demonstrate that it has taken appropriate quality assurance action in response to concerns that have been identified through its quality assurance processes. And part of that requires that the hospital also conduct some form of internal and external peer review of cases. So for this, University of Maryland Medical Center, their application reflected that they performed quality assurance through monthly cardiac surgery, service quality improvement meetings, as well as morbidity and mortality review meetings. No external reviews were conducted during this period, this reporting period. However, the hospital provided its peer review policies that detailed the triggers for both internal and external peer review of cases. And for this reason, they were found to be in compliance with this particular standard. Next slide, please. Thank you. On this slide, we would see a requirement for the hospitals the star ratings of the hospital. So in COMA, if a hospital falls below the 2-star rating, they get like a 1-star. For more than 2 reporting periods, they are subjected to a focus review. And looking on the slide, we can see that this hospital maintained a 2-star rating for all of the reporting period. There were 8 reporting periods documented on the slide. And what that means is that the hospital does not perform better or worse than any hospital. So they perform similar to every hospital that they were compared to in the SCS ACSD database. And we've talked previously about the components of this standard, and there are 4 measures. The first one is the absence of mortality. The absence of mortality has an 80% weighted rating amongst all the 4 measures. The second one is the absence of major morbidities. There are 4 components that accumulate in that. The third one is the use of an internal mammary artery for the CABG. And then the final one is the use of perioperative medications, beta blockers, and a couple of other medications. And for this reason, based on the star ratings that we see on the slide, UMMC is in compliance with the standard. And next slide, please. Next slide, please. On the next slide, I'll start to talk about the performance measure. I'll start to talk about the confidence interval. And the reason why we're talking about the confidence interval is that in the COMA, with the citation on the current slide, it talks about the fact that a hospital, and I'm just gonna read what is on that slide, that a hospital with an all-cause 30-day risk-adjusted mortality rate for a specific type of cardiac surgery cases, particularly cabbages, because cabbages at the time when this was written were the most common types of cardiac surgery cases. And it says that if that exceeds the national average beyond the acceptable margin of error calculated by the hospital, by the commission, is subject to a focused review. And essentially, what is the acceptable margin of error? The acceptable margin of error that is being used is the 95% confidence interval that is calculated for the hospital's 30-day risk-adjusted mortality rate. So talking a little bit about confidence intervals, and I'll stay on this slide for a little bit. So confidence intervals, they're just a range of values that describe an uncertainty around a particular estimate. The larger a population size is, population size in this scenario, we're talking about a hospital that has cardiac surgery program. The larger the population size, the narrower the confidence interval is likely to be, and the more confident you are in the results that you get. So for example, I know before we talked about an hospital that had cases that were less than 200 cardiac surgery cases. For that hospital, when we looked at the graph that we created, the confidence interval was pretty wide. And the reason could be because their volume is low. Another scenario in which the confidence interval might be wide is when the case is rare. You know, if there's a rare number of conditions and you're creating a confidence interval for that, you might have a wide confidence interval. So when we look at, and on the subsequent slide, we would see that when we look at the graph that we've created for UMMC, because of the larger urban center hospital, the confidence interval is not as wide as some of the hospitals that we have seen before. So that's a little bit about the confidence interval. And just on the lower bottom of the slide, we would see a graph that shows like a normal distribution, which is something that we see in statistics. This is the commonest form of distribution. We see it in natural scenarios. We see it in cases where you're talking about a continuous variable. The risk-adjusted mortality rate is it's a continuous variable because you can get an infinite number of values from that. So this is the kind of graph that you would see. And what that means is it doesn't matter. Within the 95% confidence interval on this graph means that if you were to take a random sample of 100 cases of cardiac surgery, you take a random sample, 100 cases, 95% of the time, they're gonna fall within that bell-shaped area. And you can, to a great extent, trust that value. 5% of the time, they would fall outside of that. So for 100 cases, 95% of the time, it falls within the required confidence interval. And that's what that shows. Can we get to the next slide, please? And basically on the next slide, I've just talked about what I showed on the previous slide, so we'll move on to the next slide. So on this slide, this is the graph for the risk-adjusted, the national value, the national average of the risk-adjusted mortality rate as compared to the one for UMMC. And you would see on this, you might look at it and say that it looks similar to what we had presented before. But I want us to be mindful first of the scale of this particular graph. I remember that a previous one had a scale of 14 and the intervals beyond the grid was a 0.2, was a 2, it was the incremental levels was every 2 points. So that means that the bandwidth of that might have been 0 to 14, but we see on this graph that it might look similar, but based on the scale, it's just like a 0 to 6. And what this means is it doesn't matter really on this graph, and I know we talked about this the last time, it doesn't matter where each of those data points fall, as long as they fall within the confidence interval. Because what that means is that it's not statistically different, they are both similar, no matter where it's placed. So it could fall the STS national average, which is the yellow dot, could fall to the left or the right of the hospital average. And that would not matter because all that shows is is that as long as it falls on the confidence interval, then they are similar. Next slide, please. So just a quick, and I think this is a great way to look at confidence interval again, and I'm not sure how much of this you can see, but there are three categories. The first category shows when the STS national average and the hospital risk-adjusted mortality rate fall within the confidence interval. And what that says is that they are not statistically different, they are similar. The next scenario, when the national average falls to the right and outside the confidence interval, it falls to the right of that bar and outside the confidence interval, what that means is that the hospital is doing significantly better than the national average. And on the contrary, in the third scenario, if it falls to the left of it, that means it's doing worse than the national average. And that's just a pictorial representation and something that is easily grasped, just looking at that. Next slide, please. So on this next slide, this talks about the fact that so the profile of the kind of cardiac surgeries that hospitals are performing is changing. And so because of that, we cannot just state, we cannot rank hospitals on their performance because the kind of procedures they perform are different. And there is a change in profile. We've seen recently that the cabbages on the decline and more other types of procedures are being conducted in the different hospitals. So based on that, we cannot state that. We cannot just based on this determine that one hospital is doing better than the other or vice versa. And the next slide, please. The next slide just shows, we've talked already about the first two performance measures, first one being about the risk-adjusted mortality rate, one being about the risk-adjusted mortality rate, and the other one being about the star ratings. For the final measure on the slide, it states that the program shall maintain an annual volume of 200 or more cases. And the reason for this is that programs that do not maintain this and perform 100 or less cases for 2 consecutive years will be subject to a focus review. And this is based on prior research. UMMC, based on what you can see on this slide, has maintained an annual volume for all reporting periods that exceeds the threshold of 200. And for this reason, the hospital complies with this standard as well. Next slide, please. It is the recommendation of the executive director of the commission that the commission issue a certificate of ongoing performance that permits the University of Maryland Medical Center to continue providing cardiac surgery services for the next 4 years. And with us today, we have virtually, we have Dana Farrakhan, who is the SVP. We have Michael Glancy, who is the Manager of Strategic Analytics. We have Janet Petit. We have Kristen Siddle. We have Scott Tinsley Hall. And we have possibly Bradley Taylor, who is the Chief of the Division of Cardiac Surgery. I will be glad to respond to any questions, and thank you for your time.
Thank you. Why don't we start with the motion? Do I have a motion to approve the certificate of ongoing performance for cardiac surgery services at University of Maryland Medical Center for a period of 4 years?
So moved.
Commissioner Jensen, I think I heard you first. Do I have a second?
Boyer.
Commissioner Boyer, thank you. At this point, does anybody have any discussion items or questions?
I have one question. Did they say we could give them an authorization for up to 5 years?
Yes.
And so why is this an authorization for 4 years? Is there criteria by which we determine how long the authorization is, or is it what they requested?
There is no criteria. I think it was just our assessment internally to give 4 years. We can give up to 5 years.
We give 4 years for all programs. Is that our standard?
We've been doing that, but I don't think there's any guideline that says give 3 or 4. The guideline is just that you cannot exceed 5. So whatever that number is.
The majority of approvals that we give are for 4 years.
We've given 4 for programs without issues. Yes.
Yes. Okay. That's our standard of practice.
Yes.
Thank you. Excellent presentation.
Thank you.
Thank you.
This is Constable Bhandari. You mentioned there are 200 procedures. Can you please elaborate what those procedures are? Are those bypass surgery? Are those some of the procedures are less complex or there are more complex? Can you please elaborate?
It is a mix. So for the overall number of cardiac surgeries, there is a mix. When we're talking about, so there are two things. When we're talking about the risk-adjusted mortality rate, in order to standardize it across all programs, it's being considered just for the CABGs. But when we're talking about the overall number or the percentage of procedures, it's both the complex and the easy ones. There are some guidelines on what type of procedures can be counted as cardiac surgery procedures, and they're all listed in the COMA 10.24.17. So to your question, they are both complex and non-complex procedures, and it is a wide range. But the procedures that I counted, I believe they are for procedures that we do not, for example, include congenital cardiac surgeries, but valvular surgeries and other surgeries just beyond CABGs are being considered for people 18 and above.
So there is
a diverse, they're diverse categories.
So there is a set number of procedure for the complex and less complex procedure, which each hospital has to
No,
perform.
There is not a set number. They just have to do more than 200 cases.
So they can do 199 simple procedure, less complex and one complex procedure. Are they just, do they satisfy the requirement?
I believe so.
That raises a red flag for me, at least.
So that's why when we're looking at the risk-adjusted mortality, we're evaluating them all based on CABGs, because all of them are expected to do that. And then the additional mix is just dependent on other procedures. So because we're standardizing based on CABGs, it allows everybody to have a level playing ground, sort of. Does that help?
Thank you.
Thank you.
Yeah, this is just an ongoing comment from the last time we discussed these issues. First of all, thank you for the next presentation.
Thank you.
And then secondly, I would feel more confident if the requirement for external reviews was before the trigger, and we didn't, therefore we could use it to prevent having to have a trigger and then go back and do external reviews. I think the best practice would be internal and external reviews on a regular basis. So just an ongoing comment.
And we've taken that comment into consideration, and part of the things that we thought about was the cost and the fact that before procedures get to the level where they need a cardiac surgery, there have been an initial level, because people don't directly go to the cardiothoracic surgeons, right? They've seen a cardiologist of some sort or something. So there has been a level where external reviews have been required before they are triaged to the level of the cardiac surgeons. So we think about that, and we're also considering elevating this conversation to the Cardiac Surgery Advisory Committee during one of the meetings and having the experts guide on that as well. So we've taken that feedback, we've heard it repeatedly, and we're trying to work.
Good, I mean, I've heard those arguments before, and there are counter arguments that have been more persuasive to me. And I mean, cost is, there's a cost associated with failing to do it as well.
Right.
And I appreciate that you're looking at considering. I still think that having been through this analysis multiple times, this isn't an issue of first impression for me. I think that glad that you're having experts look at it, because I think the external review before a trigger event is important in Maryland, particularly because of Maryland's history in this area.
Noted, thank you.
Yep, thanks.
Are there any other commissioners with questions or comments? Okay, with that, I'll call the question. All in favor of the motion?
Aye.
Aye.
Are there any opposed? Motion carries. Thank you.
Okay, thank you.
On to agenda item number 2, and I should add to the commissioners, don't be surprised if we have a pop quiz on margin of error and confidence intervals at the next session.
At least it won't be on naming of ships.
Agenda item 4B is the University of Maryland St. Joseph Medical Center. Cookie, please proceed.
Great, thank you. So now I'll be presenting on the application for the Certificate of Ongoing Performance for the University of Maryland St. Joseph Medical Center. As previously stated, there are several standards for evaluating the performance of cardiac surgery procedures in Maryland, per COMA 10.24.17, and again, an approved Certificate of Ongoing Performance for cardiac surgery services cannot exceed 5 years. The University of Maryland St. Joseph Medical Center is a 207-bed general hospital. It's located in Baltimore County, and it is part of the Baltimore Upper Shore Health Planning region as well. Next slide, please. So now I'll be sharing the findings from the review of the hospital's application and its alignment with the COMA standards. And again, I'll be using program interchangeably with hospital. For the first standard, again, all programs are required to participate in uniform data collection and reporting to the STS, ACSD. UMSGMC submitted all required data from January 2018 through June 2022 and is therefore in compliance with this standard. It's also required that the Chief Executive Officer of the hospital it's also required that the Chief Executive Officer of the hospital shall submit a signed letter stating that it would comply with all specified quality assurance activities, and we did receive a signed letter to that effect. And for that reason, the hospital is in compliance with that standard. The third standard on the current slide also states that the hospital would have taken appropriate action in response to concerns identified through its quality assurance processes. And these activities, it's required that it should include, it's mentioned that it should include the peer review of cases or recommended, both internal and external. And for the University of Maryland St. Joseph's Hospital, the hospital conducts regular hospital-wide meetings, such as the monthly quality of the board meetings, the monthly quality and patient safety committee meetings, quality Earth Institute meetings. And at the level, so those are hospital-wide kind of meetings, but at the level of the cardiac surgery program, they also conduct the monthly internal peer review meetings and monthly integrated care meetings that consist of varied people in the hospital system, including our providers like physicians and nurses, as well as cardiac surgery administrators. The hospital as well did not conduct any external review during this period, but provided a copy of its peer review policy. Next slide, please. So again, as compared to the prior, on this slide, we would see the rating, the star ratings for UMSGMC. And this hospital received a 3-star rating on during 5 of the 8 reporting periods, as is reflected on this table. A 3-star rating indicates that the program performed better than the average for all participants in the STS ACSD at a statistically significant level. And again, the absence of mortality is 80% weighted, and the hospital complies with the standard. Next slide, please. Similar to the prior presentation, we would see that this hospital, both the national average and the hospital risk-adjusted mortality rate fall within the width of the confidence interval, meaning that the hospital performs similar to other programs nationally, and it's meaning we're good with this program based on that. It performs like similar to other hospitals, and it doesn't differ by statistically significant degree from the national average. Next slide, please. We already talked about the first 2 standards on the slide. And for the last standard on the slide, it talks about the fact that the hospital should maintain an annual volume of 200 or more cases. Based on the entries on the slide, the hospital exceeded that threshold for all reporting periods. Next slide, please. It is the recommendation of the executive director of the commission that commissioners approve the issue of a certificate of ongoing performance that permits the University of Maryland St. Joseph Medical Center to continue providing cardiac surgery services again for the next 4 years. And with us today, we have James Ensley, who is the Executive Director of the Earth Institute, and Don Roach, who is the Cardiac Registries Coordinator. They're both attending virtually. And I'll be glad to respond to any questions. And thank you for your time.
Thank you. Have a motion? Motion to approve this. Let me read it first. I have a motion to approve the certificate of ongoing performance for cardiac surgery services at the University of Maryland St. Joseph Medical Center for a period of 4 years. I think let's get a second from Commissioner Wood, was it?
Yes.
Thank you. Are there any questions?
No.
I do have a question.
Commissioner Brzezinski.
Oh, larger question of this process. Why do we pay such close attention to these cardiac procedures in terms of doing these external reviews? Was there a history of not meeting standard of care, or was there fraud and abuse in this? You would know. And maybe this is not something to ask on the fly. Perhaps that could be an adjunct to your next presentation. But as a new commissioner here, I don't understand why we're paying such close attention to these surgical services when, as a practicing physician, we do similar internal peer reviews, quality assurance meetings for all services rendered in a hospital. But for some reason, these cardiac services are coming before this commission for this. If there's a short answer, I'd be happy. If I need to wait, I can wait.
So the short answer is that in 2012, when angioplasty, percutaneous coronary interventions was being debated, the legislature did debate whether cardiac surgery should also be subject to the more ongoing oversight that was not being contemplated for PCI. Given that these are all cardiac services, often are part of the same, obviously same organ, that the sense of the legislature was that there should be the same regulatory framework should apply to both cardiac surgery and TI. You do note that though it was generally applicable, the rules on when external review would be triggered are a little bit different, and that reflects somewhat the nature of the way care is delivered, but also the fact that cardiac surgery was not subject to the same sorts of appropriateness questions that that PCI was at the time. So this entire scope of service is subject to ongoing performance assessment, and I think that's probably the correct way we ought to approach it. That if we're talking about PCI, applying a more rigorous review strategy should also be applied to a service highly related to PCI as well, which is cardiac surgery.
So then the concern is the quality of care, the quality of outcomes. Is that what really because to me, what these reports and such, they really detail the quality of care. Are we meeting national standards of quality or not in terms of outcomes? But in terms of necessity, we're not reviewing necessity for these cases. Is that accurate? Because if we're looking to catch fraud and abuse, from what I see presented to us, this doesn't appear to be data that would highlight areas of fraud and abuse or appropriateness of procedure.
So the appropriateness criteria, I guess I would argue, are part of the ongoing oversight that we expect the programs to be applying to themselves.
Programs that make money doing these procedures?
And yes, I recognize that these are highly lucrative procedures, you're right. But I'd also note that particularly related to PCI, that in parallel with what was happening in Maryland, the ACC was moving forward with another set of appropriate standards for PCI themselves, which I think one would argue is working pretty well at this point. But the point is one that we consider. I don't know if Eileen, if you have any comments you want to come up and add anything, Paul? One or the other, but not both.
Thank you.
I mean, I guess I would say that there is also just this interest in having more ongoing oversight. Quality assurance is something that is important, and you know, the idea that you get a CON and then you have it forever seemed a little bit, I don't know, concerning. Maybe suddenly, like maybe we should have more checking in with programs instead of just getting approval and then we have no ability to say end of program. It was for quality. Just being able to have a check on that where we could take action if, you know, it's privilege, right? Like it's not everyone gets cardiac surgery, so maybe we want to be able to revoke that privilege.
Then is it, the more simplistic answer would be we do this because COMAR requires us to?
Well, a law, as Ben talked about, a law was passed, right? There was a concern on the PCI side, and that law said both of these together, cardiac surgery and PCI, and they were directed to pass the regulations.
But to Commissioner Brzezinski's point, there's a set of COMAR regulations that require us to do this. There is not a set of COMAR regulations that requires us to do it for some of the other services that you mentioned. Is that correct?
Right. Yes, this is unique to the cardiac service.
So then the question, right?
So,
so that makes sense why we do this for these cardiac services. And then what does COMAR expect of us to try to catch, and I'm sorry to go back to this, but if we're looking for inappropriate procedures being done that are not medically indicated, I don't see anything here in what we're being presented that will highlight us to this. And there is intrinsic temptation as a care provider myself that you get paid for procedures you do. That I don't think counting on the facility themselves to police themselves, the appropriateness is.
Is there anything in the quality assurance reviews that addresses appropriateness in this area? I don't know the answer to that. Yes.
Not really. I feel like the focus is more on the quality of care. Like, are they doing the internal review in terms of the procedure itself? And was there a problem, right? Was there a problem in terms of preoperatively, postoperatively, during the operation? I feel like that is what our focus has been on, right? Getting.
And if that's, that's consistent with what COMAR expects of us, then we're meeting that standard.
Well, then it's an interesting question for the internal quality assurance questions, because I know that in some healthcare facilities, internal quality assurance reviews of cardiac programs include appropriateness reviews.
Yeah, I think.
And I would think that that is true in the other institutions that I'm not intimately familiar with. So that, if that's true, that would be the only place in what we see where appropriateness would be addressed.
So,
the internal reviews that are conducted, each of the facilities as part of COMAR is required to conduct as on PCI does look at appropriateness, and we get that some of that data if appropriate, if there are questionable procedures being flagged at an excessive level. Is that correct, Ali? How do
I mean, I guess it seems like a little bit different on each side, right? PCI, should you be doing a procedure at all? And with cardiac surgery, that is sometimes a question that they look at, right? Was this patient so high risk or had so many things going on, you should not have done the surgery at all? That can come up. That can be something we can see potentially in information we get from a hospital. So in that sense, get the information, but I feel like that is a little bit of a different question. That's like the judgment, right? Versus someone is like committing fraud, right? Because they're saying someone needs a procedure and they don't need it at all. It just seems like it is a little bit different.
Can I ask the question just phrased a little differently? Is the scope of our mandate under the statute to review the quality or to review the appropriateness? Both.
I mean, it's covering both. There's an emphasis on appropriateness, in particular with PCI. To me, there's quality for both of them, and it's more so quality on the cardiac surgery side.
So going back, talk about the debate, legislative debate. I think on cardiac surgery, one of the big concerns were volume levels at some of the centers that had authority to perform cardiac surgery. And as Eileen correctly brought out, this is a an lucrative service, and there was concern on the evolution of treatments, and as PCI became more the first treatment for many patients that were presenting with DEMIs or severe cardiac disease, that we would see a drop off in cardiac surgery, and therefore we should be looking at that as we move forward in parallel with the PCI expanded authority. And I think I'd have to go back and really dig some of that up in terms of what the legislature really felt about why there was agreement. Obviously, the bill passed, right, that we should not just focus on PCI, but should be also focused on cardiac surgery. But as staff noted, the framework in which we were looking at it was a little bit different. Recognition that for angioplasty, PCI, there was questions at the time about appropriateness. I think there was much less question about that when it occurs for cardiac surgery, but there were questions about volumes as time went on, and a desire on the part of the legislature to put a regulatory framework on cardiac services that kind of looked consistent, regardless of whether you were delivering PCI or cardiac surgery.
So if I might, looking at the analyses we've done today, we have always looked at quality for cardiac, not appropriateness. And COMAR, if the standards for cardiac surgery focus on quality, they don't have any COMAR standards for appropriateness that we've adopted, do we?
For cardiac surgery?
Yes.
Yes, not in the direct way that there is for PCI.
So I think the question of should we be looking at whether the surgeries are appropriate, not really is a question we should maybe pass to the staff to look at the regulations. But as we sit here today, I'm trying to steer us back to this application. The COMAR standards that we're under today talk about quality, and it looks like they've met all of those standards today. It seems like a fair question for follow-up as to if we don't do appropriateness, is that because the statute doesn't want us to, or is there another reason? Look at that, this is a separate issue. Does that make sense?
Yes, the questions I ask here have no bearing on my concern about the qualities of this program in discussion at this time. It was more of a general question.
No, that makes sense. So are there any other questions or discussion?
I do have one question.
Go ahead,
this is a question for the applicants. And you don't compare programs that you, and the debate occurred from the operators that we shouldn't do that, but it does lend itself to a quick comparison between St. Joe's and the academic center. Just a question on how patients are directed between St. Joe's and the academic center. It does look like there are perhaps more complex surgeries being done at the academic center, given the fact that the isolated CABG case share is much smaller at academic center compared to St. Joe's. But do you have any insight in that if I show up and I assume seeing a treating cardiac surgeon would have privileges for the part at both the academic center and at St. Joe's? Is there anyone available to answer that?
I think we have James and John. I've seen John on the line.
I'm the executive director of cardiac services at St. Joe's. I can speak a little bit to that if you guys will allow it.
I'm afraid you're not coming through. You can barely hear someone talking.
How's that now? Can you guys hear me a little better?
Yes.
That sounds better.
Yes.
Great. This is JB Hensley. I'm the executive director of cardiac services at St. Joe's, and I will do my best to answer that question. I think the initial statement around complexity of the cases is generally correct, although I would add a bit more specificity. St. Joe's is an advanced sort of tertiary community hospital that has the capability to take care of nearly all cardiac surgery conditions that are presented through our ED or via other transfers of referring hospitals, with the exception of advanced mechanical support cases. We do typically, if a urgent case requires, we can place a patient on ECMO, but don't have the capability to really, or staff, to maintain that assisted support for a long period of time. So typically those cases are transferred to the medical center. If a particular patient and referring provider may have a desire to be operated on by a specific surgeon that typically works at St. Joe's, you're right, Commissioner, that we do have, those surgeons do have privileges at the downtown campus, and oftentimes will go downtown and do that surgery there. So there is a bit of a complexity shift, but for the most part, St. Joe's is well equipped to handle almost to the very tip top of the acuity scale complex cases at the community hospital level.
Thank you.
Any other questions or comments? With that, I'll call the question. All in favor of granting the motion?
Aye.
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 Are there any opposed? The ayes have it. Motion's passed. Thank you.
Thank you.
That's nothing.
Yes, to the conference room we were in prior to this one.
The TV, I think, is on in the conference room. You can see the proceeding. Agenda item 4C, MedStar Union Memorial. Katie Nerrell, Program Manager in the Division for Acute Care Policy and Planning, will provide an overview of the staff report for MedStar Union Memorial Hospital. Katie, you have the floor.
Thank you. Good afternoon, Mr. Chairman, Commissioners. So MedStar Union Memorial is an acute general hospital with 191 licensed beds located in Baltimore City. It's part of the MedStar Health System, which includes 6 other hospitals in Maryland and 3 in the DC area. The hospital has been providing cardiac surgery services to adult patients in Maryland since 1994. The hospital is part of the Baltimore Upper Shore Health Planning Region, which includes Baltimore City, as well as a number of counties, including Anne Arundel, Baltimore, Caroline, Carroll, Cecil, Hartford, Howard, Kent, Queen Anne's, and Talbot counties. There are 5 other hospitals in this health planning region that provide the cardiac surgery services. If we can go to the next slide, please. Okay, so this slide shows 3 of the key standards required for the approval of a certificate of ongoing performance. The first standard shown requires a cardiac surgery program to participate in data collection and reporting through the Society of Thoracic Surgeons Adult Cardiac Surgery Database. That's the premier clinical outcomes registry for adult cardiac surgery. MedStar Union Memorial Hospital has complied with this standard by submitting all required data and information to the database, as well as to MHCC for the review period of January 2018 through December of 2021. The second standard found on this slide requires the hospital CEO to sign a letter committing to all quality assurance activities required by MHCC regulations. Because the hospital provided a letter of commitment signed by President Bradley Chambers, Union Memorial Hospital was found to meet this standard. Next on the slide, the standard shown requires that each cardiac surgery program demonstrate that it has taken appropriate action in response to concerns identified through its quality assurance processes. Actually, if we could go back to the previous slide for just 1 second. Yeah, thank you. We're looking at the last standard here, shown here. And we have seen that Union Memorial Hospital has complied with this standard. They submitted documentation showing that the hospital conducts monthly multidisciplinary quality improvement committee meetings, as well as monthly cardiac surgery service line meetings. And they take action on concerns discussed in these meetings as appropriate. Additionally, I'm pleased to be able to tell you that every mortality is reviewed both internally and externally at Union Memorial Hospital. The external reviews are performed by physicians at the Cleveland Clinic in Ohio. Next slide, please. this slide shows the hospital's STS star ratings for cases where a coronary artery bypass graft or CABG procedure is performed in isolation. As you can see, MedStar Union Memorial has received a 3-star rating for 3 of the 5 one-year periods in calendar years 2018, 19, and 20, and all 3 of the 3-year reporting periods from 2018 to 2022. The hospital's 3-star ratings indicate that the hospital performed statistically significantly better than many of the other cardiac surgery programs nationally. Next slide, please. So the graph on this side is similar to what Buki showed. The hospital compares to the national average in terms of the all-cause 30-day risk-adjusted mortality rates for isolated CABG cases. And our key here shows that the yellow dots, the STS national benchmark, the red diamonds where the hospital falls in relation to this benchmark, and the gray bar displays the 95% confidence interval for the hospital's performance. When the confidence interval for the performance includes the national average, the hospital's performance does not differ significantly from the national average. So as you can see on this slide, MedStar Union Memorial Hospital is performing similarly to the national average for isolated CABG cases for all of the 12-month reporting periods shown. And therefore, they also meet this standard.
So, and I should have asked Buki this, I think I pulled a fast one by waiting until you presented to ask my statistical question. But to just recast this a little bit, I see the gray bar as long as the hospital's diamond is inside of the gray bar, I'm 95% sure that the results are about average.
The hospital, the gray bar is actually the 95% confidence interval for the hospital. So as long as the yellow circle is within the gray bar, the hospital is similar to that.
And what that means that I could feel with 95% certainty that it's average results.
Yes, yes, according to a normal bell curve. We can go to the next slide, please. So I just covered the first 2 standards that appear on this slide. The final standard shown requires each program to maintain an annual volume of cardiac surgery cases of 200 or more. Although this standard was waived by MHCC in 2020 and 2021 due to the COVID-19 pandemic, as you can see, MedStar Union Memorial exceeded the volume standard for each calendar year reported. And were found to be in compliance with this standard. Next slide, please. So based on the staff's review, the executive director of the commission recommend that the commission issue a certificate of ongoing performance that permits MedStar Union Memorial Hospital to continue providing cardiac surgery services for the next 4 years. Before concluding, I would like to note that I believe we have with us today, Ms. Cheryl Lennon, Regional Vice President of the Cardiovascular Service Line at MedStar Union Memorial Hospital. Thank you for being present virtually, Ms. Lennon. And with that, I end my presentation. Thank you, Mr. Chair.
Thank you, Katie, and welcome. So we'll start with the motion. Do I have a motion to approve the certificate of ongoing performance for cardiac surgery services at MedStar Union Memorial for a period of 4 years?
Motion.
Moved Commissioner Brzezinski. Do I have a second?
Second.
I think, I saw Commissioner Boyer and Wood. We'll do Commissioner Boyer's head second this time. And with that, does anyone have any questions or discussion? Sounds like we're getting discussion down. All in favor of the motion?
Aye.
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 Are there any opposed? Great, motion passes. Thank you very much. With that, we move to agenda item number 5, which is a presentation, an update on the work of the HSCRC Post-Acute Care Work Group. At the beginning of this year, HSCRC convened several work groups intended to generate ideas and policy recommendations to improve quality of care, increase care coordination, and reduce costs. Paul Parker, Director of the Center for Healthcare Facilities Planning and Development, has facilitated meetings of the post-care and long-term care work group. He will brief the commission on the group's discussion of issues and ideas to date, as reflected in its 2 meetings. The policy approaches to changing the way in which payers, hospitals, and nursing homes improve and better coordinate care for the Medicare population is an important regulatory context for MHCC in our current time of severe challenges for both of these types of facility. Paul, please proceed.
Good afternoon, Chairman Sargent, members of the commission. Full disclosure, I think one of the reasons I'm here providing this report is because this is a work group that has work in progress, but so it has not reached conclusions and recommendations yet. But so pretty recently, we thought we were going to have an exceptions hearing on a CON application on this month. As often happens, the applicant withdrew. And so I think Ben saw this as an opportunity to get me in front of the commission one more time before I
actually. If you had done something wrong, you was punishing you.
Next slide, please. First slide. So a little background. What are we talking about here? Post-acute care is treatment following a discharge from acute care hospital. We include hospital level rehabilitation, which in our state health plan is termed acute rehabilitation, skilled nursing facility services, home health agency services. Hospice services is a little different, but in some context, it could be also viewed as a post-acute care service. And then outpatient rehabilitation services. Specifically, skilled nursing facility services are a Medicare benefit for providing rehabilitation services following discharge from a hospital. There has been in federal rules a 3-day required hospital stay, although that has been waived because of the pandemic. We will see if that will continue. Medicare can cover up to 100 days of skilled nursing facility care. The average length of stay is much shorter. The payment is 100% for the first 20 days of care. And co-payments begin afterwards. Almost all of Maryland's comprehensive care facilities or nursing homes are certified by Medicare to provide SNF services. Among the most common therapies that are provided are physical therapy, occupational therapy, and speech language pathology services.
So Paul, who pays the this is Commissioner Bhandari, who pays the co-payment after 21 days and how much is the co-payment?
Well, I think a patient would have to either pay out of pocket or rely on benefits that they purchased through a supplemental insurance program. Of course, there's Medicare Advantage. Thank you. Well, depending on eligibility for Medicare.
Thanks.
So the problem outlined for this work group has to do with HSCRC's total cost of care model, which came into place in 2018. As part of that agreement, HSCRC committed itself to achieving a required level of savings. This actually is incorrect statement here because it should have referred to total Medicare savings by the end of 2023 rather than Medicare spending. Sorry about that. Between early 21 and early 22, we saw the trend in non-hospital Medicare spending in Maryland, which of course includes post-acute care, significantly exceeding the national growth trend. Prior to 2021, the Maryland trend more closely aligned with 2022. The gap between Maryland and the U.S. trend moderated. However, growth in non-hospital Medicare spending in Maryland continues to exceed growth in what we see for the country as a whole. The past 2 years, HSCRC has not met its agreement objectives of moderating hospital spending growth or achieving specific savings targets in Medicare spending. Slide, please.
think we're 2 behind now, so you want to go to the problem or the work?
I want to go to here. I know. So to provide you with a little color contrast with this black bullet points one after another. This is it's a series of charts, and I won't spend a lot of time on these, but I thought it might be good to kind of illustrate what I was just talking about in terms of the challenges for HSCRC's payment model. So this is looking at hospital spending, and all of these slides are Medicare spending. This is showing you the actual growth trend since January of 14, when the payment model first moved toward a global budget revenue payment model for controlling hospital spending. And as you can see there, we were doing pretty good till, of the 2019 year is when we first started seeing the Maryland trend actually popping up above the orange trend. And what you see there is you see the drop in spending that occurred in the spring of 2020 and summer of 2020 when the pandemic first emerged. Then you see that very sharp spike, Omicron spike. And as you can see, right at the end of this period, we did see some better performance, but this kind of illustrates, as you can see, that blue line kind of riding above the other line that illustrates the problem that HSCRC has recently confronted in terms of its agreement requirements. Next slide. So this is showing you the same period of time, and this is non-hospital spending. So this would be not only post-acute care services that are paid for by Medicare, but also physician services, a whole gamut of services that Medicare would pay outside of the hospital setting. Here again, you're doing pretty well for quite a while. Then you see, especially with that Omicron spike, you can see a significant increase in Maryland spending compared to the nation. Again, that persisted for a while. Last couple of months of this period, which ends in November of 22, you'd see some better comparative figures. Next slide. So this is showing you the whole picture, both hospital and non-hospital Medicare spending per capita. Essentially, what we're seeing here is that when we look at the first 11 months, calendar year 22, as compared with the first 11 months of calendar 21, the hospital side, significantly higher growth in spending when comparing those two periods compared to the national reported experience. And then much closer comparison on the non-hospital side, but still Maryland is going faster spending as a whole. Next slide. Here we're going back to that same time period, January of 14 through this, and this is actually showing through November of 22. They have a 23 projection date on there that I don't think is actually captured on the slide. This is, again, total cost of care spending, all Medicare spending. So it really is combining two of those previous graphs. Next slide. Again, Medicare total cost of care. So this is everything, and that first set of bars actually combines the bars that we saw in the previous slide. And this is also breaking down Medicare Part A, which would be hospital and the acute care, the post-acute care spending, versus Medicare Part B, physician and other outpatient services. Next slide. And then this last chart, I know this is in some ways difficult to interpret, but the note that you'll see on the bottom there, a positive number represents his savings, excess growth. So when we think about that $300 million in Medicare savings, if you were seeing the same graph for the period before January of 22, so if you see thinking to the left here, if you were looking at 21, we were achieving savings. So that dotted line would actually be below the horizontal axis. Now you're seeing in this 11-month period of 2022, we kind of crossed the bar and we're now seeing increasing distance from achieving our target. We did see a reduction in the excess growth month of November 22. But this kind of represents the gap. We'd have to close this gap and then start getting into savings for the total cost, because this is both hospital and non-hospital, in order to get back on track with the model. Next slide. So the work group and several other work groups, as Ben mentioned in his update, were formed at the beginning of this year and charged with generating ideas and policy recommendations to improve quality of care, increase care coordination, and obviously the context of the model, reduce cost. The specific initial charge that the group received, and this is a subject of discussion too, was really focused on skilled nursing facility care and looking at ways to improve that type of care and also reduce cost. And we were looking at the episode of care that involves admission to a hospital, stay for at least 3 days under the longstanding rule, and then discharge from the hospital to a skilled nursing facility and the stay that occurs there. The work group includes hospital and nursing home representatives and staff from HSCRC, the Maryland Department of Health's Medicaid program, and MHCC. After an informal group discussion in October, we've had 2 official meetings of the work group. We have a 3rd meeting next week. And I don't know if there will be a 4th meeting. There will certainly be, I think, discussion and interaction continuing. But we're really looking to give HSCRC some work product from this work group in April with some recommendations. Next slide, please. So improving the quality of SNF care, and what I'm doing in these final slides is really just trying to give you in a very summary way a flavor of the discussion. So improving the quality of SNF care while reducing cost can be achieved by reducing the length of stay for patients, skilled nursing facility rehabilitation, and reducing readmissions to the hospital by SNF patients. Reducing readmissions appears to be the bigger opportunity for both quality of care improvement and cost reduction. Maryland does have a higher readmission rate of SNF patients back to the hospital. I think average length of stay is more comparable to what's achieved in the rest of the country. Cost reductions can also be achieved by reducing admissions to general hospitals that are likely to result in discharge to a SNF, and by substituting other forms of post-acute care for SNF care, such as home health care. Most of the work group discussion has focused on reducing how to reduce readmissions of SNF patients to the hospital. And this will require improvements in case management of SNF patients. So the idea here is that if we have nursing homes, and this could obviously happen in collaboration with hospitals, really monitoring what's happening to these patients after they start a stay in a skilled nursing facility, so that they can intervene on an early basis, provide appropriate treatments to improve the condition of the patient, reduce the number of serious episodes of illness or injury. That's the way that you're going to be able to reduce readmissions back to the hospital and keep the patient in the nursing home until they've completed their course of rehabilitation. Next slide.
And generally speaking, the point of you need better case management is like a traffic cop saying this maybe shouldn't be going to the hospital, this should be in the SNF, maybe this shouldn't be in the SNF, this should be at home.
Yes, that's a fair statement. So a lot of the discussion has been, how do we realign incentives? So hospitals.
I heard a question from Commissioner Jensen, I believe.
Yeah, how long has skilled nursing facilities been covered by the payment model administered by HSCRC?
It's not. It is, we do not regulate charges by skilled nursing facilities the way that we regulate hospital charges.
So that 20 days, 21 days, and 100 days, that's nationwide standards.
So hospitals are strongly incentivized to reduce admissions. That would, of course, include readmissions. Under the global budget revenue model, your budget, you can think of that as a guaranteed pot of revenue during the rate year, and that's based on an expectation that you'll have so many admissions to the hospital of these types that should cost this much. And if you are reducing admissions, you don't get penalized. If you can reduce admissions, then you retain the revenue while obviously reducing the expenditures that you would have otherwise had to undertake. And so the misalignment, of course, is that SNFs operate under a fee-for-service payment model. Unlike hospitals, they are successful in reducing readmissions. They don't necessarily, improve their bottom line. Reducing the potential Medicare revenue stream can also occur there, because obviously if a patient goes back to the hospital, it's a medically necessary stay of 3 days, and then goes back to a SNF, there's the opportunity for additional revenue for the facility. So one of the initial proposal that was considered by the commission and offered by the work group rather, and offered up by a member of the work group, was to do, Commissioner Jensen, what you just alluded to, bring SNF under the total cost of care model with direct regulation by HSCRC. I think the notion there was that this would make it easier to realign incentives. If we essentially said we're going to have a payment model that applies to both the hospital stay and the post-discharge stay, the skilled nursing facility. Next slide.
How was that received?
Well, I'm going to talk about that. some further points. Under the current global budget revenue model, and hospitals are strongly incentivized to reduce admissions and readmissions.
Would the hospitals not also be strongly incentivized to shorten the length of stay? With global budget revenue system. If revenue to the hospital is relatively fixed.
Yes.
Less time the patient spends, they're more incentivized.
They are. In a general sense, they are. I think when you think about hospital stays and hospital admissions, though, if you're reducing hospital admissions, you're tending to reduce admissions of lower acuity patients. Patients that you can actually, you don't necessarily have to address their problems by admitting them to the hospital. And if you're successful doing that, then the average acuity of your hospital patients that are still coming into the hospital goes up. You can see this in the recent experience. We've had a long trend. This has been disrupted by the pandemic. There was a long-term trend of reduced hospital use rates. And by that, I mean admissions per thousand population come down substantially in the last 12 years. But what you saw, and this is kind of what you would expect to see, is a corresponding increase in the average length of stay. Achieving both reduced average length of stay and reduced hospital admissions is a very difficult proposition because of the nature of what it means to reduce hospital admissions. We have seen definitely a strong trend toward increased average length of stay.
Without rate regulation, a hospital could also share some of its global budget cap with the SNF to reduce regulations, right? Could it not provide an incentive for the SNF to take its patients?
Yeah, and so what are the incentives, though, that are involved here? I'm going to go off bullets here a little bit, basically covering the same thing. So what are the incentives that are available? Yes, a hospital and a SNF or a group of SNFs, a group of hospitals decide to collaborate with the objective of let's reduce readmissions back to the hospital after we discharge patients, maybe reduce the length of stay of both the hospital and the SNF. What is the incentive for the nursing home in that collaboration? And I think the incentives we have is kind of the preferred provider model. You have this relationship, then the SNF is willing to actually work on reducing readmissions, upping its game in terms of good case management, in order to get a steady stream of patients from that hospital or group of hospitals. So it's kind of a volume versus it's a trade-off between volume versus, you know, the benefits that may derive from sending that patient back to the hospital when they present, when they get into a situation that makes it more difficult for the nursing home staff to manage.
Excuse me?
A much different incentive than what the hospitals are experiencing.
That's a pretty heavy lift.
Yes.
Commissioner O'Grady has a question.
Yeah, it seems to me you're getting down into the details, and I'd just like to make sure I understand the overall dynamic here. So we moved forward a few years ago, the state did, to move beyond simply hospital target in our negotiation with CMS, to move beyond hospital to total cost of care. And when we did that, we had what had proved to be over a number of years an effective strategy for managing hospital costs. But on this move to total cost, we left the gate open in terms of these other parts of healthcare spending and expected anything other than what we have seen. I mean, this is not great design work in a public policy sense. And Paul, I'm just amazed by your understated, this is your last meeting. You can say whatever you want. But the idea of thinking that you work out a model that works on a subsection.
Encourage folks that this is a public meeting.
You go to a full scale implementation and then just left the barn door open over here and over here and over here. This seems perfectly rational of what the hell did they think was going to happen? Of course, if you have this big chunk still on fee for service, they're going to behave like fee for service, where the incentives are. They don't have any incentive to reduce their care. and you can tinker and you can try and think about cooperative things. But it seems to me that your work group's kind of third bullet there of, you better get these guys under the umbrella. I mean, my question at the end was going to be, which senator and, you know, who's drafted the language to stem this hemorrhage before we have a 2023 that is in just as bad shape as it's going to be? Because all the winds are blowing in the same direction. If I don't, why would we expect any post-acute-care provider to do anything other than maximize, you know, they're providing care. It's not like they're cheating the government, but we've seen this 50-year experiment with fee for service, and you're like, you know, they're not fair to their stockholders if they don't do these sorts of things. So we can talk about how they'll try to manage, but without a fundamental change in the incentive system, is there much chance that we'll see anything better than what we've seen? And the feds, of course, at some point will catch up with us and say, the model's not working. You can't do total cost of care, Maryland. You cleared the pandemic and then you exploded again. Am I missing something?
Well, I definitely know where you would be coming from if you were on this work group. In my defense, in terms of not, you know, of being understated, I think is the way you put it at this point in time. I am supposed to be facilitating the discussions that go on in this work group. So I do feel restrained and
This is Commissioner Metz.
Taking a position right now. Please, okay. Commissioner Metz.
Yes, I'm on this work group. It basically what it boils down to is under this total cost of care and the dollars flow back through to the hospital's cost. Commissioner O'Connor's correct, and you know there's no incentive. But with that being said, there's no margin left in long-term care whatsoever if you remove skilled care. Everybody understands what that is here. They're underfunded by Medicaid, break even at best. So obviously they're going to be very protective of that. The last proposal there that Paul was speaking to, as far as some type of sharing in the savings, obviously the hospital wants all the savings, and skilled nursing is coming back saying that doesn't work. Now, nobody's saying that anybody should be providing care that's not necessary. And I run a nursing facility for 30 years, and you know, typically we're going to have around 15 or 18% skilled. Most of that's going to be physical therapy, occupational therapy, speech therapy, etc. So, you know, we played this game. We do have a relationship with our hospital, and we do meet to try to reduce admissions. Admissions to hospitals aren't necessarily great things for residents, unless it's absolutely necessary, and that's where you want to see it. So there's a game being played by the hospital with observation periods, et cetera, instead of admitting residents into the hospital. Families get upset because a resident will come back that was at the hospital for 4 or 5 days, not be admitted. They can't understand why they don't qualify for more skilled Medicare coverage. So we deal with that. There's no easy fix on this. If you take this revenue away from skilled facilities, they won't exist. So there has to be some type of compromise, and I think that's what the last proposal listed on this slide is kind of pointing to, if that makes sense to everyone.
What if instead of bringing rate regulation to skilled facilities, bring skilled nursing care under regulated facilities, like a swing bed, you know, which is doesn't exist here in Maryland, but in other states, it's in the critical access hospitals, where hospitals are able to, just as we have observation status, admitted status, they have a similar de-escalation of what they call swing bed status, which is basically a skilled nursing status in the hospital. And if, you know, rate regulation won't work for skilled nursing facilities, perhaps providing some skilled nursing care to stabilize the patient a little bit more before they go to a skilled facility, doing that in a regulated facility might allow a more stable patient to leave there. And also, if our spend for regulated facilities is relatively fixed across the state, then perhaps that would reduce the cost per admission or cost per stay. And you know, that was when I read through this ahead of time, I thought perhaps that's the thing to do. If we're spending a fairly fixed amount on inpatient or regulated space, then let's, as consumers of that space, let's use that space more and drive down the cost per use for the patients. That was my brainstorm on this, but anyway.
And back in the 90s, we actually saw a lot of interest by hospitals in having their own skilled nursing facility units. I don't think that that paid off in the way that they thought Medicare reimbursement or post-acute care was likely to change. And those essentially have gone. There's only really, I think, maybe 3 hospitals left in the state that have any sort of comprehensive care facility unit within the hospital that they run. But yeah, I think there is a question of, you know, why aren't hospitals looking to vertically integrate? Why don't they buy skilled nursing facilities that they can then have total control over the whole?
It's not even like I know our hospital is one of those last 3 with a skilled facility in our walls, but legally it's a separate entity and it's a fee-for-service entity housed in this hospital. But perhaps, you know, the swing bed option is they are not leaving the hospital facility; they're still there and they're receiving funding through those funding streams, not through the fee-for-service. Anyway, just
is the answer to why they don't vertically integrate because they can't make money on the skilled nursing facilities?
Maybe.
So, and is there really any other alternative to untying this Gordian knot? You have to either align the incentives or live with the outcome of fee for service and total cost of care.
Let's go
in the work group. What is a viable alternative?
Let's go to the next slide.
Yeah, I fed that one to you.
Can I ask one question? Just this almost
trying to get you
kind of stuck on what it seems to be a math problem. We have the global budget caps on the hospital side. Gives them great incentives to get people out of the hospital. They leave the hospital, right? Go to SNF. They charge extra money. You're now underwater because you're paying a global budget cap, plus you're paying for the SNF. Is there anything you can do with case management for the SNF that like saves you money unless you reduce the global budget cap? Like it's always more money, isn't it? Am I missing something?
that's kind of what I saw as well. And I thought just
like, if we're not talking about shrinking the global budget, what are we saving? We're just paying more than we would have paid if they're all in the hospital under the cap.
But aren't you then penalizing the regulated entity for actions by non-regulated
entity? I'm just trying to figure the math problem. It's like 3 + 1.
Yeah, okay, well, let's see that to me sort of, let's see the other slide.
Yes.
So the question would be, comes from that, is on that slide where we're gone underwater from the national average, are we paying global budgets plus, because there's a lag in our adjustment of the cap for the change utilization, and that's just going to be part of our problem, is that unless we adjust the global budgets, we're going to always be underwater.
I'll add to the savings that you generated.
I was honestly asking. Maybe I'm missing a piece of my equation. Is there a piece of that equation that I'm missing?
I don't think so.
Okay, never mind. Go ahead.
No, the savings from hospital, the hospital retained revenue is being shared with nursing homes, physician programs. You heard me talking about consumers. Consumers want some savings from hospital savings too. So it doesn't seem like there's enough savings to go around. I worry.
Yeah,
it's just not. So,
currently, there's none. You know, it just you got a fee for service entity and a global budget entity, and you're only taking money out of the global budget, not going to work.
And this does not organically self-correct.
Okay.
There's no feedback cycle.
Because even if you take money out of the global budget, you haven't solved the problem of the skilled nursing facility continuing to generate more readmissions than perhaps it needs to generate because its incentives are different. So you continue to take money out of the hospitals without fixing the problem.
Yes, I mean, you have to manage the fee-for-service side while reducing the budget by some amount.
Under the
but we don't have any ability to manage the fee-for-service side.
Under the realignment, you would be giving, you would be rewarding.
If we change the incentive,
you'd be rewarding the skilled nursing facility for reducing readmissions. So
now keep in mind also, if you change the incentives and bring it in under the umbrella of a total cost of care, a more managed total cost of care, and you link that, which you'll probably have to do for political reasons anyway, with something that I think Jeff would like raising Medicaid rates. So you're not trying to subsidize, the loss you take on Medicaid by either Medicare or private pay. You're now in a situation where you might trigger something along the lines of what we've seen with the consolidation of buying up physician practices. So the hospital has a flow into their operation. They would now have an incentive to set up after you leave the hospital system as well. And so you might trigger the buying up of nursing homes by hospitals. But now they're on the hook for the whole thing.
So then you're going to have the hospitals and the skilled nursing facilities in a situation where skilled nursing facility is going to have to be doing this constant math, which is, would we be better off just doing fee for service and not taking this volume from these hospitals? Right?
Are there any other?
So you still really have.
But do we then blow our deal with the feds? We miss our targets. We overspend.
Let's go to the next slide.
Yeah.
This is the slide I've been asking. So the response to that initial proposal, bring SNF services under the payment model, under HSCRC control, is leave the SNFs outside, but create various types of programs within the total cost of care model that encourage hospital and health system collaboration. And so we have heard, the group has heard in its last meeting, we heard about collaborative arrangements that were undertaken by University of Maryland Medical System and Frederick Health. Next week, we're going to hear about LifeBridge and what it's doing in working with nursing homes. And I think the problem with these, I think my takeaway from those presentations is that yes, they are making some positive changes and they are improving, I think, quality of care, skilled nursing facility care, but they didn't tell us a lot about how much of a reduction they're achieving. And so the advocates of the more direct approach are basically saying just that we're not really fundamentally providing the kind of incentives for skilled nursing facilities to change their behavior and thus change the readmission rate that are going to amount to much. So I think the basic debate that we're seeing is between someone who really has some experience in this area and has been part of projects designed to look at what happens when you change these incentives versus at this point, I think the hospitals and HSCRC who are saying, we don't want to go in that direction. We want to figure out how can we tweak the model in ways that get us more impact. And we can create a set of rewards for specific hospitals, specific hospital systems engaging with specific nursing homes. So
if I was gonna simplify it, dumb it down for me, right? You got a discussion going on between some person or group of people who are suggesting bring SNFs under the model, and another group of people who are suggesting we can tweak this model with the different incentives and try and make it work. And CMS has got really the thumb on the scale by saying, we don't like bringing SNFs into the model anyway. So essentially that ain't gonna happen.
well, I think you can think of it in terms of, do we want the heavy hand of government, kind of making this a universal kind of change? Let's bring all the skilled nursing facilities under that model and then have a more direct path to realigning incentives? Or do we want to, have voluntary action that we encourage and incentivize, but it's voluntary. It's going to be the individual players in the market who will respond to some program that lets them realign incentives within their own particular market.
In something that's far less than a free market, because it's a heavily regulated market that's being tweaked a little bit.
Well, it's Medicare.
Yeah. But CMS, I mean, I think that's the thing. CMS says they don't like the idea of bringing SNFs in. So the odds of that happening are what? I mean, my own handicap on that would be somewhere, hovering around 0.
Well, that was what was expressed by the HSCRC representative on the work group. Is that accurate?
Yeah,
definitely he threw cold water on the idea of going back and adjusting the agreement in the way that's recommended by expanding the regulatory scope.
My take on the history of those negotiations is Maryland doesn't have a lot of leverage with CMS in negotiation of the model. I mean, there are discussions that go on, but CMS does more of the design than we do because they got the money.
Yeah, at the same time, it seems inconsistent with the current administration, where they have kind of taken up a challenge that, they like a government-based approach rather than a Medicare Advantage market-based approach. They're more comfortable with that, and that they want to show that they can manage better than their previous fee-for-service colleagues can. So the idea that they would, not take a more comprehensive management approach just seems inconsistent with what their leadership has said. So I guess I would be tempted to try and verify that is really where like you say, if they've already decided before a proposal even put before them that they're not going to accept it, well, that's sort of a non-decision at that point. But it's as if the Trump people came in with, we should regulate everything. You know what I mean? It's just not consistent with, the CMS. These are a lot of people I worked with for a lot of years, and they are true believers in the government does a better job. So I kind of don't buy it without at least some more information that they would now turn 180 degrees and just want to leave them out. I think that the nursing homes and the other folks have a fine argument that they can make about we're not making much money here, but then sweeten this pot with a Medicaid rate increase so they don't have to dance around with cross subsidization.
Well, and if I was CMS looking at what happened when they regulated hospitals, it cost them more. So why would we put more services into a system that costs more than the existing?
Sometimes you do. I mean, like when you offer health insurance coverage, your expenses go up because now people have coverage. You've improved quality, you've improved access, but now you're paying for things you want to pay for. It's not, You know, Arkansas had a lovely Medicaid program and it didn't cost very much because nobody got any care. So you are going to see some of that. And they're making a bet on this kind of a deal that you'll see increases in costs in early years, and then you'll see savings down the line. And I'm just afraid Medicare is saying that that's not happening. We're just seeing increased costs.
Thanks. Sorry to cut you off. This is an ongoing work group. I expect we'll hear echoes of these same debates as this work group goes forward.
They will be producing a brief statement about what they think HSCRC should do about improving its chances of getting post-acute care.
Is it going to be along the lines that we've discussed today?
It's going to be based on the discussions of this work group. And, I don't know if we will achieve consensus.
Right.
It may be reported that it has opposing views. There's opposing views right now.
I'm concerned that I don't see it. There's like a view A and view B, and I'm like, I don't think view A or view B will work. So, are you the?
They're looking for ideas and brief policy recommendations.
Right.
They want to take those. You know, there are more than one work group, so they're working on different approaches and different parts of the problem, and then work on the detail after this, what they call model progression work.
And it's a high level discussion for sure. I mean, given the brevity of the group's meetings, you're not going to be able to come out with a fully formed policy.
Are you our representative?
What it'll mean.
He's the big guy right there, and I'm also on the board. So there's two staff.
So are you wrapping this up before you go to Hawaii, or who's taking your place?
I'm going to try to wrap it up as much as possible.
By this in Hawaii.
But Ben is perfectly capable of bringing it home. Yeah.
So there are four, at least four, maybe five groups. We're involved in three: the post-acute care, the consumer engagement, and the physician group. And you know, one of the benefits you've kind of seen it all is that all of them kind of in one way or another are thinking we're going to take money from the hospital global budgets and incentivize someone else. So you know, my earlier worry is that there's just not enough money going around. But for the broader context, we're talking about the model that goes into effect in 2028 time period. So there's going to be a lot of discussion going on. HSCRC has requested these work groups complete their work by the summer of 2023. That will go into sort of the negotiating stance of the state as they start talking about the longer term model beginning in 2024. Sure, as you know, there'll be some back and forth. This is just really kind of getting the very precursors of policy recommendations together, not determinative at this point. You know, the fact that each of these groups is only meeting 3 or 4 times does demonstrate that they're really trying to get just some precursors to policy recommendations.
And when do we renew our agreement with CMS?
So there's between 26 and 28, there's a pivot period. The key point for the model in Maryland, I think, is this evaluation that's coming out from CMS in 2026. That's going to be, you know, I guess, determinative of thumbs up, thumbs down for the next 10 years.
Next round. Yeah.
So, but the other thing that is throwing a wrench in this is that HSCRC and CMS, and to some extent MHCC staff, are hearing about the CMMI new idea, which is called the AHEAD model, which they're trying to homogenize a model that would work for multiple states, including Maryland, that would include some elements of the Maryland model, perhaps some elements of the model from Vermont or from Pennsylvania, et cetera. And that would be appealing to multiple states. And CMMI would get away from what I think is probably a source of frustration, which is all of these one-off state-based initiatives that are very, in terms of state equity are an issue, and in terms of administration, I think are an issue. That's my opinion on why they want to do this. But the Hospital Association in Maryland, at least at this point, said, we're not really very interested in this head model. We don't think the state, because if you have a homogenized model, there are probably things in that new model that are not well aligned with what's happening in Maryland up to this point. So there are two real initiatives going forward, or three really. The current model, which Paul's, I think, done the best job yet, anyone I've seen of characterizing what the challenges are. That's going to continue. The next version of the model, and then the side issue on the outside stretch of the head model, which my sense is that's really what leadership at CMMI and maybe at CMS overall wants to move everyone towards: more similarities, more comparabilities between states that want to be out in the lead in terms of healthcare reform with the federal government, that they have a kind of a common template as opposed to here and there and different things. That's my.
I think just from a policy perspective, this is a head model, or bringing, the SNFs under the regulation, or just not passing the test and saying, hey, we're out. Any of those options, well, said another way, are going to create large disruptions in healthcare, which may over a period of years generate a better, more efficient, rational system. But there's going to be a lot of disruptions. The only way to avoid that would be to just sort of tinker around, the model that we've got. So there's a degree, I think, and I see anyway in this. Is there any appetite for that disruption? And people are rational, and I think most of the folks that are running large organizations don't have much of an appetite for that. So,
your comments about CMMI wanting to homogenize programs across states, that seemed to be a trend we saw on the MD-PCP Advisory Council as well, that as they started talking about making changes, it all seemed to go back to a primary care first program that they have rolled out nationwide, and a lot of the recommendations started to make MD-PCP look fairly indistinct from that. So
yeah, and you've got healthcare systems and SNFs in Maryland are well designed over a bunch of years to produce exactly the results that they're producing right now under this system. But if you change that, there's a lot of hard things that are going to happen. Like there's a whole lot of hospital beds in Central Maryland that are probably not needed. If you look at, per capita of bed ratios in similar cities.
But I think your earlier point was the correct one. I see what would CMS certainly would love it if their job was easier, but we don't have 6 regional Medicaid programs. We have 50 or 52 or whatever. And why would any senator or congressman see this as all they do is piss people off back home? I just don't see this as politically viable. I understand why they would like to do it. And if you're talking about something like how we pay oncologists, maybe I can see that they don't want to have 50 different ways of paying them. And they probably won't. But on something like the Maryland model or the Vermont model, I don't want to hurt our feelings, but I don't think Vermont's very interested in doing what we do. They don't want to be under homogenized either, and they will mobilize as we will
I think we'll let Paul finish though, and we will almost certainly find out which way we're going with it. Interesting discussion.
I live long enough, I will.
Thank you for the interesting discussion. And I think we're hitting on the same issues that the work group struggled with, I'm gonna guess.
There is one final slide. Please change the slide.
With the answer?
No.
Good question.
No, I want the answer.
Next slide, please.
Yeah, did you want to ask us the name of some kind of vote?
Or slide. Here we go. So I won't spend a lot of time here. There are definitely what I was hearing, and I don't know if this is going to end up being a kind of a definitive part of the answer here, but certainly some of the nursing home industry representatives, they seem to be leaning more toward the idea that yes, we're not going to be able to tweak the total cost of care model to create the kind of definitive financial incentives that are needed. Although I'm not sure exactly how they're thinking about how bringing SNFs under HSCRC regulation would work exactly. I put a bullet point in here about the fact that we have fairly low uptake of Medicare Advantage plans, which obviously can be quite different in terms of the possible ways in which SNF is used because from the fee-for-service Medicare model. And then the final point here is that this discussion is occurring at a point in time when certainly what I'm picking up is that we're in a very difficult situation to move hospitals and nursing homes in this particular context in a better direction, because the pandemic seems to have created a real crisis in terms of staffing nursing homes. Certainly serious challenges for hospitals and other healthcare facilities too, but anecdotally, the hospitals have been talking to us about the fact that they have kind of unprecedented numbers of patients backing up in hospital beds that they cannot discharge, even though they are ready to discharge skilled nursing, because the skilled nursing facilities that are receptive to taking those patients has been greatly reduced. They don't have the staff resources to increase the census of skilled nursing facility patients that they're managing relative to the demand that's coming out of the hospitals. And if you're trying to get a patient out of a hospital to a SNF on a weekend, forget about it. It's just not going to happen. So the market, the way it's functioned pre-pandemic, certainly not functioning that way now. It's just another complicated factor I wanted to let you all know about. I hope I've whetted your appetite for what this group may finally merge with, but I'm really not sure. Give me Commissioner O'Grady for not taking a stronger position one way or the other right now, but we shall see.
You're welcome. If you want to extend your period delay retirement and hang around, you can see what the outcome is.
I'll think about that.
If
I can indulge you for...
Is that in the form of a motion?
Question.
Royer, did you have a question?
No, I was just saying, is that in the form of a motion that he extend his retirement date?
Never pass a motion that you can't enforce.
If I can indulge you just for a minute.
Yes, sir.
That said, I am retiring, leaving the agency. I just wanted to express my appreciation for the leadership that Ben has provided. At 3 executive directors in my tenure. They've all been good, but Ben, I think has been extremely supportive of the work that my center does in health planning and CON regulation, in the good times and in the bad times. And I really appreciate that. And also Randy in particular, your work on modernization of CON project. Very much appreciated, provided great leadership on that group. Didn't get everything we wanted, but we got some important changes last few years. I very appreciate that. And lastly, those of you who have been reviewers and those here virtually, you know who you are. I really appreciate the time and effort, sometimes painful, that the reviewers here that I've worked with over the years have put into this regulatory process. Very much appreciate it.
Thank you, Bob. With that, we have an overview of upcoming activities from the Executive Director.
So I have mentioned a couple. One is that we hope to have the Horowitz Center present on their plans for more for working with state agencies to engaging consumers. I'm been interested how that's all going to work out, but more help we can get, more, I think we should welcome that. I also will be asking Ken's staff to present on the status of the Where the Cost initiative. It's been a lot of work just to go forward from transfer this from the chief vendor is Signify Health. They signaled they were getting out of that business, and we are contracting with a larger company, Change Healthcare. I know that Caitlin and Alexa have worked very hard with the council for that organization, which is now owned by Optum, to get a contract squared away. But all that has meant is a number of delays. I know that the chair has asked repeatedly, where is it? And we are investing a lot in Change Healthcare, now the current owner of Prometheus, the episode grouper that we use. We are not without leverage because it's also the grouper that HSCRC uses in their EQUIP program. That is a program that engages physicians in sharing some of the savings that would be generated from more efficient delivery of certain episodes of care. Again, the savings are being spread to other providers. Hopefully there's enough around, but the real issue here is the episode grouper. MedChi did suggest, or the state considered developing their own episode program. I think even with the participation of Care First, that'd be a risky endeavor. But I want to bring the commissioners up to date on what we're doing and maybe opening up the window a little bit to see some of the challenges of trying to present episode-based payments, which are one of the vehicles going forward that are defined under value-based care. We expect to have, keep our fingers crossed, a number of CON modifications to come forward. The inflationary trend we're on has generated its expected impact on hospital construction projects. And we hope to bring one for Laurel. This will be the second modification due to cost that is being sought by Laurel, as well as Shady Grove, which was approved a couple of years ago. They have not, they made a two-phase project. They now tell us that the money they expected to spend on the total project may not actually cover the first phase, which is the construction of the tower. So we are awaiting some work on rates that HSCRC will have to complete, but we expect to bring that forward very shortly as well. I do think there are a couple more CON actions that they've had a brief hiatus from CON actions before the commission, but next month we expect at least one more. I would note that it's not because they've not been doing anything. Commissioner Brumbot and Commissioner O'Grady can testify to that, but they served on as reviewers, but the applicants in both of those cases opted to withdraw their applications over the last 2 or 3 weeks. And so they are released from their obligations, not without my profound thanks, along with what Paul has already said. These are challenging jobs for commissioners to take on. And like those of you who have done this before, I want to thank them for the work. They did miss the opportunity to present to the commission, and we'll try to figure out how to accommodate that opportunity in the future. Maybe we'll ask Commissioner O'Grady to talk about the Medicare Advantage program, which is my last topic, which we did manage to skirt. There was a bill put in by some of the Medicare Advantage plans that would have had state subsidized Medicare Advantage rates. I think Tracy's gone. It doesn't look like that would get it's going to get any traction from the legislature, in part because it doesn't make sense, but in part, but in part because the revenue picture in the state just doesn't look as promising as it did 6 months ago. And putting aside 150 or $200 million to stabilize the Medicare Advantage market probably is something we can't afford. And I'll stop there, but stay tuned. I really appreciate all the interested, committed comment today from all the commissioners. For those here, after conclusion, there's some tasty treats and sugar in the comments.
Thank you. Thank you, Ben. With that, as we have made it through the agenda, I want to thank everyone for their engaged participation. So I have a motion to adjourn.
Motion to adjourn.
Motion to adjourn.
Second.
Thank you, everyone. Have a great day.
Thank you.
You all. Distribute those savings. I mean, we're really thinking to generate savings. Why don't we just take that?